the Rising Star program at WACh with Irina Draguna, who's not here today, but hopefully she's online. So the Rising Star project was started last year. Nii was one of our first inaugural cohort of Rising Stars. And the idea was to provide seed funds and extend some of the benefits of being at the University of Washington to researchers who were clearly on a trajectory to be the next big thing in global health. And really, really pleased to welcome Nii here today, because his application was actually our first contact with him at the center, and it was just very, very clear in the application his dedication to the work that he does, and that he was very, very much on this trajectory to become a leading researcher in his field. He'd already achieved a lot before he joined the program, and so we were keen to be part of his success. So the program itself provides $10,000 of seed funding, but in addition to that, we give a visiting scholar position here at the University of Washington, albeit virtually, that allows us to extend some of the data management resources we have here, the library resources, some pre-award support for grants, as well as networking opportunities. And that's really what we're sort of here today to do, is to learn from Nii's experience and to see some of the amazing research that he's already achieved, but also to provide an opportunity for everybody to get to know him a little bit, in the hopes that some of you will be inspired to reach out and maybe collaborate in the future. Nii's particular focus on adolescent health and mental health seemed very aligned with what both of our centers do, both at WACh, but also in the global mental health arena. And so again, when we read his application, we were just struck by what an amazing researcher he is, and how relevant what he's doing is to our work. So I'm going to shut up now and let Dr. Nii get on with it. Over to you.
Right, Kirk, thank you very much, and thanks to all your other colleagues there. I'm also grateful to all the participants who are available in person and those online. Right, so let me get on with it. Yes, as Kirk said, I'm just going to share with you my journey so far in the area of adolescent and youth self-harm and suicide prevention. But I have captioned my talk this morning, Suicide Prevention in Africa, my little research contribution. My full name, as I have it on the screen, is Emmanuel Nii-Boye Quarshie, a long one, but Nii for short, N-I-I. I believe in North America, someone will say Nii. I always hear that, but it is Nii for short. Okay. And I'm speaking from Ghana. I believe that people have heard about the name Ghana, but often what I have had the chance to correct is that people misconstrue Ghana to be Guyana. They are two different places. Ghana is not the same as Guyana. Guyana is a sovereign state on the north coast of South America, but Ghana is in Africa. And that's where I'm speaking from. On the world map, for example, as I have on the screen, you will find Ghana on the west coast of Africa, the side bordering the Atlantic Ocean and closest to the Americas. Ghana is pretty much at the center of the world, being both closer to the equator and also on the Greenwich meridian, which represents 0-degree longitude. Many people have argued and clearly the position has been that Ghana is the country that is closest to the center of the world. So I invite you someday, if you plan your holidays, please pass by and say hello to the center of the world. Okay, so that's just about my geographical space and location. This morning, I'm speaking just about 3 things. First is that I want to share with you my academic or research background and an overview of my career so far. And then I'll quickly share with you the story about the Rising Star award projects that I'm on. I'm not through yet, but I'll share with you where I have reached so far, and then I'll share with you what next steps I have in terms of this particular project and also my career in the next half decade or so. Right. So, about my academic and research background, in terms of training and education, I have a bachelor's degree from the University of Ghana. I majored psychology and minored sociology. And I left that university in the year 2008. And then the next year, 2009, I was lucky to have a scholarship to go to the Norwegian University of Science and Technology, where I studied human development, but with particular focus on cultural and community psychology. Thereafter, I returned to my home country, Ghana, where I was engaged by the Department of Psychology at the University of Ghana as an assistant lecturer. So that was how, or that was when my academic life actually started. Then, so between 2012 and 2015, early part of 2016, I was lucky again to have another scholarship to go to the University of Leeds in the UK to study or read for my PhD. My PhD was broadly within psychological sciences, and the focus of the training was around suicidology and applied health psychology. After that, I was lucky again to be engaged by the School of Medicine of the University of Leeds as a postdoctoral research associate, which was quite very useful. Thereafter, I returned home again and got engaged back by the Department of Psychology at the University of Ghana as senior lecturer. Currently, that's my status, and that's what I am doing. Right. Now, my research area, once again, is adolescent and youth self-harm and suicide prevention. My focus is widely on low and middle income countries, but more specifically on those that are within sub-Saharan Africa. Of course, they say charity begins at home, and that's my home space. So certainly, if I have something good to offer, I should start from that space. Right, but definitely I'm open to collaborations from other contexts around the world. I imagine that a lot of people will be thinking, and I have had to address this concern nearly at every event where I share my story or career story. People will tell me self-harm and suicide are a heavy topic. How did you get into this? I mean, how did I get here? Sometimes it rings in my head. But, well, my answer has always been serendipity. It was, I never wanted to be in the area of suicide. In fact, at the University of Science and Technology in Norway, my supervisor and her team were actually into suicide research, and they are known globally. But I would not get into that area. It was too heavy for me at the time. So I didn't want to. They asked me explicitly, wouldn't you do something around suicide? Clearly, I was interested in young people, their psychosocial well-being and things like that. But the subject of suicide was just too much for me. I just was not ready for it. Until two things happened. One was that it was towards the end of my master's degree, I lost my mom. And the news came to me in a very shocking way, because I had spoken to her on phone on a Sunday. Monday afternoon, she passed away. And when the news came to me, it shattered me. I mean, I couldn't overcome the trauma of it. Eventually, I had to seek break from studies, travel back home, be with my family, attend the funeral. Everything was done, and I was still in that state of denial And what happened was that I had to seek professional help because I was still not overcoming the trauma of that loss. So during the process or in the course of seeking help, I encountered other patients who were also struggling with traumatic loss and complicated grief and so on. And I was surprised at some point because my therapist told me that I was doing well in terms of recovery because relative to other patients he was seeing at the time, some of them were experiencing suicidal ideations and were having tendencies to end their lives. And that information also shook me a bit. And I was surprised. I mean, how could a human being think about ending their own lives? Because I feel life is important, life is treasured. And for some of us who are from highly religious contexts, we believe life is sacred. You have no right to take your life or end it. And life is sweet. When you are sick, you struggle to get well because life is good. And I just couldn't understand how come, somebody would feel that way of wanting to end their life. The second bit of that experience had to do with volunteerism. Fast forward, I had done well with recovering from the traumatic loss, gotten back to Norway, completed, returned to Ghana, engaged with the Department of Psychology as an assistant lecturer. Then I met two people, Professor Charity Akotia and Professor Joseph Osafo. These two people are known suicidologists in Ghana. They had just won a grant and they needed the support of research assistants. And at the time, I was very good with qualitative research. I know people who are quite familiar with the Norwegian University of Science and Technology will attest to that. They are quite, robust with qualitative methodologies. And so we came back home with that skill set. And these two scholars engaged myself and another colleague to run interviews for them on suicide issues. Well, I had told myself I wasn't interested in research or anything career related about suicide. No. But of course, I was ready to volunteer to help these two good people in my department. Now, it was during the course of the interviews and analyzing the data that was emerging from that study that I got that nudge, that interest got sparked within me that this is an interesting area that is quite fascinating. And that was how I got into suicide research. I mean, listening to the narratives of both young people and old and middle-aged people and the troubles they were going through in life, how they were struggling to navigate their way through, fascinated me. And I thought that I was well placed, I had opportunity, and I could help, at least through research. And so if you are also seeking to find out why this heavy topic, how did I get here? Please, this is my response. For short, it was serendipity. Now, I want to just go a little more into my journey so far in terms of career and research. And here I want to focus on my little contribution that I have made, that I continue to make to suicidology broadly in Africa. Right. And I have split this story into two stages or two parts. The first stage I call towards the repeal of Ghana's anti-suicide law. Now, by 2011, I had gotten baptized into suicide research and other advocacy and other such engagements related to suicide prevention, particularly in Ghana, by these two leading suicidologists in our country, Joseph and Charity. Now, suicide at the time was a crime in our laws. It was highly stigmatized. Still, it is stigmatized. And it was seen as a sin by religious people. And also, it was completely abhorred in our society. Still, it is. So anybody who was into suicide research had to battle these forces. Now, fundamentally, you need to take away the law. If the law is still criminalizing attempted suicide, then anybody who is in that space working can't make any progress because you won't get the support of government. That enabling environment will not be created for you to make any headway in terms of the prevention of the behavior or phenomenon. And so the first hurdle we needed to tackle, and I saw that I needed to give it my best and support my team towards that agenda, was to get the anti-suicide law of Ghana repealed. And so we started that journey in the year 2011, or rather, I had a chance to join the team to fight. Suicide is a reality in Ghana. In fact, as I talk to you, the latest statistics from the WACh suggest that annually about 1,993 people, representing 177 females and 1,816 males, die by suicide. Now, this represents crudely 6.6 per 100,000 people. It's important to understand some quick history about Ghana's anti-suicide law. Ghana's anti-suicide law was bequeathed to the country through British colonial rule in 1960. But the paradox is that by 1961, exactly a year when we had taken the law, the anti-suicide law in England and Wales were repealed. But we kept ours until early part of this year, 2023. Now, specifically, the law stipulated that anybody who attempted to commit suicide committed a misdemeanor. And indeed, we have evidence from our research over the period to show that persons who have been found guilty of that law were given hefty fines or were jailed in some cases. So the journey to repealing the anti-suicide law. Ghana had no data on suicide because it was a crime, so no official data on it. If we were moving towards repealing the law, then we needed to have evidence, for example, on the attitudes of Ghanaians generally towards the law and persons who are suicidal or suicidal persons. And so we started off with studies. We thought that we could champion our advocacy and the drive towards the repeal agenda by using data, evidence. So the first strand of evidence we needed was evidence on the attitudes of the generality of Ghanaians and key stakeholders towards the anti-suicide law. And so we did several studies, and I was privileged to be part of all of those studies. Quite a number of them, I was the lead researcher and so on. And we included several stakeholders, media practitioners, lawyers and judges and magistrates. We also did papers involving community leaders, the police who were required to enforce the law. So the first strand of evidence, attitudes towards suicidal persons and the law. And what we saw generally was that some people, I mean, in the minority in terms of our participants, were for the law because of its supposed deterrent effect, which really doesn't work. Most of our participants were against the law, including police officers and magistrates and lawyers and judges and media practitioners. The other strand was to get epidemiological data because government was not gathering data on suicide and suicidal behaviors. So epidemiology, on my side as, if you like, the leading researcher in terms of adolescent and youth self-harm and suicide research in Ghana, led several studies and projects in that direction. So among adolescents in school, among adolescents out of school, like street-connected adolescents, those who are homeless and so on, and then adolescents who also are in the minority or who have been minoritized, for example, those who identify as gender and sexual minorities and so on. And the evidence was quite troubling because many of these young people reported feeling suicidal and actually having attempted the behavior. The third strand was to examine the experiences of persons who had direct experience of suicide itself, and those who were living with the effects of the phenomenon. And so once again, in my space, dealing with young people, I participated in studies, some of which I actually led also to look at the lived experiences of adolescents in terms of self-harm and suicidal behaviors. The fourth strand, which is quite important, is advocacy training and key stakeholder engagement. Now, it is important to mention that all of these studies that we were doing and the trove of evidence that we were building were not just being kept on the shelf or being reported in academic journals. We had a translational orientation in that anytime we ended any projects, we brought together the relevant stakeholders for whom the data was important. And we had training for them. So for example, we had training for traditional leaders. We had training for the police, teachers and other school staff, including school counselors and so on, religious leaders, community members in general. We had training for health professionals, lawyers, judges, and magistrates. We had training for media professionals, among other important key stakeholders, because we needed to change attitudes. We needed to help people or professionals and lay people in our country be well positioned to offer support to persons who were experiencing suicidal tendencies, because our position was that, and still remains, that suicide prevention is everybody's business. But most importantly, we needed people to understand that decriminalization is important if we really want to do meaningful suicide prevention. Now, whilst all of these were going on, we were also knocking on the doors of our parliament, because in Ghana, we run the parliamentary system. And if you want to change laws, you need to go to that place. And so in 2012, we put together a petition and submitted to Parliament. Unfortunately, we didn't get any feedback on that particular petition, because at the time, we hadn't built enough evidence to warrant such a grand agenda of decriminalization. But between 2012 and 2017, we had built enough and extended our network in terms of collaboration and so on. And so the research base had broadened relatively. And so by 2017, we put together a second petition. And this time we were able to strike a chord in Parliament, and we had some hearing. We got into some conversation, even though that also did not materialize in the ultimate goal we wanted, which is decriminalization. But we got Parliament talking. We got some key stakeholders coming forth to engage with us. At this point, I'd like to take a quick detour and share with you some two things that happened to me in the course of all of this. So fast forward, research is still building. I had gone to have my PhD, but whilst on the PhD, I was still working with my team in Ghana. Nearly every year I was back home and participating actively in all of these things. And I didn't know somebody somewhere was watching. I was sitting somewhere in Ghana, working with my team, and calls came through, recommendations were written. And in Australia, I think the 31st World International Congress of the International Association for Suicide Prevention thought to honor me with the prestigious DeLeo Fund Award, recognizing my outstanding contribution in terms of suicide prevention research in developing countries. Then another thing happened the year 2022. Once again, I was actively involved with my people down here in Ghana, locally trying to push for the decriminalization agenda, and the overarching organization in Ghana, which is the Association for Suicide Prevention, elected me to be the president of the association. Now, GASP for short, call it Association for Suicide Prevention, GASP. Now, GASP is the overarching non-governmental, non-religious, non-political, non-tribal body that brings together and coordinates the efforts and activities of individuals, groups, and organizations towards suicide prevention in Ghana. Now, we have presented our second petition in 2017. We're still working and building evidence as we go into the COVID era and everything. By 2021, we had another idea to begin to get some champions in the Parliament of Ghana. So we had three people, three MPs, very respected MPs indeed, who opted to champion and sponsor a private member's bill towards the decriminalization agenda. Remember, we had already kept up some conversation or sparked up some conversation with our second petition in 2017. And so things were happening, but we needed somebody who could push this for us within Parliament. So these three people, Honorable Bernard Ahiafo, Honorable Kwame Enyimadu Entry, and Honorable Francis Xavier Kojusosu, together, we reached out to them and they were happy. In fact, some of them had also directly or indirectly experienced suicidal issues. And so they had their own innate motivation towards that agenda of decriminalization. We put through the private members bill, and in Ghana, if you want to change a law or make a new one, it must go through various stages. First will be a reading, which is the first reading on the floor of Parliament. It goes through a second reading, and when all amendments have been done, it comes for a third reading. If that is approved, it goes for presidential assent, and that becomes law. As I speak to you, our private members bill went through all of these phases, and fortunately, on the 28th of March, it was a Tuesday, Ghana's Parliament amended sections of the Criminal Offences Act of 1960, which criminalized attempted suicide. And as we speak now and onwards, we hope that we can sustain this. Any person who attempts to take his or her life will be considered a mental health issue, and that will require assistance by law. So this is one of the landmarks, or if you like, achievement that myself, together with my colleagues here in Ghana and team, are super happy about, because then it launches my career to the next stage that I call ground zero. Ground zero in the sense that now the law has been cleared. It means that we have to start everything afresh or anew. Start building national databases and surveillance systems, get policies in place, get some concerted efforts and policies so that we can get suicide prevention on the national agenda. That way we can also engage government in terms of support towards suicide prevention and self-harm prevention. So when I say ground zero, of all the things that I have mentioned, for me, and in terms of my career, I see two important things. One is intervention studies. We've done quite a number of the epidemiological studies and the, if you like, some of the observational studies. And so what we need is to start thinking about developing or employing robust research methods to develop interventions to inform culturally sensitive policies and the development of clinical manuals and interventive protocols to support both professionals and non-specialized mental health workers who handle suicidal issues. Then, for me again, I think we still need some further observational studies, including, once again, epidemiological studies, because the evidence is still not enough. Because when I look at the population of interest to my research, and I deal with young people, I think that there are a lot of groups who are young within our population who are still not part of the evidence we have. For example, when I look at the marginalized and minoritized young people, typically who are always excluded or underrepresented in public mental health research, for example, pregnant adolescents, teenage parents. We still have teenagers who are themselves parents, even though they also need parents, but they are parents. And we have no idea some of the mental health struggles they are going through. Street-connected adolescents and homeless young people. I have tried in the past to engage them in suicide research. At the moment, we have a few strands of evidence about them, but I think that we need to go some more into their world. Now, young people who are living with disability, think about those who are deaf, blind, and so on. And those who identify as gender or sexual minorities. Now, young people who are living in rural communities, those living in conflict and post-conflict context. As you may be aware from the news, West Africa recently has gotten the attention again for the wrong reasons. We are seeing a lot of military takeovers. Generally, you find countries living at peace, but you still find pockets of conflict in some regions within the same country, and Ghana is no exception. Now, these young people who are living in contexts like this, what are we doing about their mental health? And of course, those who are out of school, who are not in education, who are not in employment, who are not in training. So in my space, dealing with young people, I feel I still need to push some more in terms of the observational studies, particularly the epidemiological ones, so that we'll see where to direct interventions and where to direct, efforts and so on. At this point, I'd like to mention to you all of these studies that part of and those that I have led in my recent past, where we've gotten the funding to support them. One of them is the Carnegie Corporation of New York, the Solidarity Fund for Innovative Projects that is run by the French Embassy in Ghana, the Leeds International Research Scholarship, the ORACh of the University of Ghana, the Office for Research, Innovation and Development, and then the National Institute for Humanities and Social Sciences in South Africa. Right, now let me come to the other important subject for this presentation. The second bit, which is the result from the Rising Star Award project. Now, I just mentioned that for the next phase, I'm looking some more, or I want to look some more at the young people who have been left out of our public health research. Normally, we focus just those who are in school. But in Africa, when you talk about young people, when you go to the classroom, you are not going to get a fair representation of young people. And so I believe that we have to look at those who have been marginalized or left out of the spotlight. And for me, focus my Rising Star Award project on pregnant adolescent girls in Ghana. Specifically, I'm looking at suicidal behavior in this young population. Now, my anticipated date for completion is March 2024. Now, at this stage, I have made some progress, and I just want to share with you how far I have come. And then we see what happens to me next. Okay, now in terms of background, I'd like to say, specifically in relation to suicidal behavior among adolescent girls, suicide is the third leading cause of death among girls aged 15 to 19 years, and that is according to the latest WHO statistics. Now, among pregnant girls, like I have intimated, the behavior has been overlooked. In fact, even among older women who are pregnant, we still don't know much in terms of suicidal behaviors. But it should be worrying if you don't know anything about this already vulnerable young girls who are also pregnant. Now, even among adults, pregnant women, we still see issues of mental health. So you can imagine if you want to extend the problem onto adolescent girls who are also pregnant, because there are reports about major depression among these young people. And we know that major depression is a critical risk factor when it comes to suicidal behaviors. The challenge, however, still remains that in low and middle income countries, including Ghana and generally low and middle income countries in sub-Saharan Africa, we still don't have enough evidence about suicidal behaviors among our young people, including adolescent girls who are pregnant. So for this project, I aim to explain just 4 straight things. One is to estimate the prevalence of suicidal behaviors among adolescent girls. And here I'm looking at, when I say suicidal behaviors, I'm looking at ideation, planning, and attempts. Then identify some of the methods for suicide attempts that these young girls report or have used. Again, to describe their reasons or motivation for attempting suicide. And then finally, identify some of the commonly reported social, demographic, and psychosocial factors that are associated with the behavior. And I mean ideation, planning, and attempts. Now, how did I go about this? So it's a cross-sectional study, cross-sectional survey. I followed the Strobe guidelines. Now, 3 major hospitals in Ghana were selected. Now, in Ghana, there are 3 major tertiary hospitals, and in Italy, they have been placed, if you like, geographically across the country. So when you go to the northern part, you have one. In the middle belt, you have one, and then in the southern belt, you have the 3rd one. And then they also have their associated polyclinics. Now, I included households because not just in Ghana, but across sub-Saharan Africa generally, the evidence suggests that young people or young girls who are pregnant will not attend or will not be consistent in attending antenatal care. And so often they are at home and they get additional vet attendants who will provide them care. Sometimes they don't attend at all. They don't have anybody at all until they are due to. And so it was important, if I was interested in representation in terms of my sample, to also see if I could pursue some of them in their household. So those who I encountered at the facility, the health facility, I inquired from them if they knew somebody else like themselves who were in their communities or things like that and would not attend antenatal clinic. And they volunteered information. They introduced me to such young women. I contacted them and then administered the questionnaire. So I used the SDQR, Suicidal Behavior Questionnaire Revised. It's a 4-item questionnaire, the Patient Health Questionnaire, the WHO5, and among other standardized instruments. And most of these have been assessed generally to have satisfactory psychometric properties in the African context. I plan to run some multivariate regression analysis and to see what factors are associated with the behavior and so on. This study received ethical clearance from our ethics committee for the humanities here at the University of Ghana. So in terms of the sampling, this is how it flowed. I think I was just talking about it. So I got the country into 3 parts: the northern zone, the middle zone, and then the coastal zone or the southern zone. I approached 463 potential participants because I didn't know, and we don't have any records about how many young girls are pregnant out there. I used the Cochrane formula for calculating or determining sample size for proportions where the population size is unknown, and made provision of 10% for non-response or missing data, and that gave me 422. In all, I approached 463 potential participants, and I had 449 agreeing to participate and giving complete data. They were aged before within the age range 14 to 19 years. Okay, so this is the distribution across the 3 zones of Ghana. The northern 175, central middle zone 152, southern and coastal zone 122. At the moment, data collection has ended. In fact, I had to end it on just Monday, yesterday. and we entered the last batch of data into the data analysis software. And so data collection started from August, and we just ended yesterday. So at the moment, I have not really gone into finishing the cleaning up and everything. What I have just done is to have a sense of what total number of complete data I have, just for the purposes of this seminar, and to let you know what progress I have made. Now, what next for me in terms of this project? Right away, I will zoom into formal analysis of the data. Next is dissemination. Already, I'm spotting some conferences, both local and international ones. And then, obviously, I'm targeting open access publication of the key findings. My immediate plan also is that it will be interesting to see how the key findings of this study will inform the development of clinical protocol and mental health aid manuals for our primary healthcare system. And so I hope that by the time I'm through with the analysis and everything, I can begin to initiate some conversation with some key stakeholders and then see how things will go. In terms of my career, I'm looking forward to further funded projects that will focus more on intervention studies, because my sincerest hope is that this data I have is going to point to some, or is going to give me some pointers, definitely for intervention. Then I look forward to mentorship. Of course, I'm not there yet at the top, but I believe that in Africa, we still need more hands and more, brains in this space. We need more people in this space of research. Like I said earlier, suicide, self-harm, these are heavy topics, but we need more people to do this. And so I plan that even though I'm not yet a superstar, I'm looking forward to engaging more with my undergraduate and graduate students, see how I can foster mentorship, help raise some more hands into the space so we can push these frontiers forward, just for research, but also advocacy and intervention. Then finally, I look forward to more cross-national collaborations in this space. I'd like to end, but before I do that, I want to say a big thank you to the WACh, particularly the University of Washington in general, for putting together this seed grant package. It's very helpful. Specifically there, I want to say a big thank you to Stephanie, Kirk, and Irene. These three people have been very fantastic, and I've always been on my toes because of their consistent support. My mentors, of course, both here and abroad, my family, my friends, and my colleagues who may be amongst those who are participating online, and those of you around the beautiful table, the square table on my screen. I see you all. So thank you very much. I thank you for your attention.
Thank you so much. I didn't realize you could see us, but from the square table comment, I think you probably can see us. But I wanted to just say, as you were talking, there actually was a remarkable degree of engagement and focus in the room on what you were saying. I know on Zoom you can feel like you're speaking into the void, but there were a lot of notes being taken and a lot of people really, really listening to what you were saying. I will attempt to moderate some questions now, and maybe I can afford myself the luxury of the first question. Your talk was really remarkable, and your work and the team's work around decriminalization of suicide in Ghana is truly, truly inspirational. And there's so many parallels with other aspects of human behavior that have been criminalized through the legacy of colonial policies or the ongoing export of colonial laws onto the continent. I was wondering if you feel like you could tell us a little bit of the kind of policy landscape outside of Ghana. Are there many other countries across the continent that still have these issues with criminalization? And do you feel that people are kind of taking note of of what Ghana has achieved and wanting to follow in your footsteps?
Right, Kirk, thanks very much for that question. So yes, there are a few countries out there, obviously not too many from the African continent, who have a national level suicide prevention policy. And what is happening is that there is that encouragement to other parts of the world to sort of begin to consider formulating national level policies. In fact, at the moment, recently when we had our the 32nd International Congress for Suicide Prevention in Slovenia, one of the things that came up was that we wanted to find out whether really having a national suicide prevention policy has a direct translation into suicide reduction or prevention. It's still a fuzzy space. We don't have clear-cut evidence yet, even though some are saying, well, there isn't that direct relation. Others are also saying, well, you could have some impact and so on. But clearly, I mean, intuitively, if we can have a policy, at least you get the support of governments and we can make more concrete efforts towards suicide reduction. So on our part in Ghana, we are looking forward to having one, not just on paper, but keeping our eyes on the ball by ensuring that the content of such policies are implemented, and then we'll be able to, across time, evaluate whether or not these policies are translating into reducing suicide in our country. Thank you.
Fantastic, thank you. I can see Sophia online has their hand raised. I'm wondering if you would ask your question, and then perhaps if there are any questions from the room, we can go then. Sophia, able to come off mute? Do we know?
The Q&A.
Yeah, let's have a look. Okay, perhaps we can put people online can type their questions, but we have an anonymous question. Say this is very, very interesting and important work. Thank you for sharing today. They're interested in what, if any, frameworks for suicide may be used in your final analysis. A common one referenced in the US is the interpersonal theory of suicide. Nii, over to you.
Yes, definitely the IPT, how we popularly call it in the space. I know definitely something will come up about this because there are some of the variables included in my studies that align with the IPT elements, and so clearly I look forward to that. Deploying that or using that theory in explaining some of the findings. But thanks a lot for that.
Questions in the room?
Hi, Nii. Can you hear me over here in the far corner
Yes.
of the square
Yes.
table? Hi, my name is Anna Larson. I'm a postdoctoral fellow here at University of Washington and also interested in perinatal mental health. I know that as you're pursuing your analyses, you're starting to think about intervention studies that could work in your setting for preventing suicide among perinatal youth. I'm wondering if you have early ideas of what you'd like to pursue in that area.
Please take the last bit again. You're wondering
if you have some early ideas of intervention studies that you'd like to pursue, or interventions that you sense may be useful in this context.
Yes. So the bit about the intervention at the moment is not too clear for me, but in terms of our previous studies, those studies that, for example, I have led that we've conducted in school young people, We have identified some of them because among that group, we have seen good amount of prevalence studies. And so, for example, we've seen that help seeking is an issue among our young people in senior high schools. So we need to consider something around help seeking. Could it be exploring informal help seeking strategies, or helping our counseling system, the general mental health atmosphere of our schools, so that young people can be encouraged to seek formal support? And also issue about families and in school young people. The idea is that it seems that some families need empowerment. The basic issues about parenting still need to be, championed among many families in our country. Now, in terms of the pregnant girls, I am thinking that most likely we may have to consider the formal help givers. And here I'm talking about nurses, I'm talking about medical professionals and so on in our health facilities. In our country, when a young person who is not married becomes pregnant, they tend to be victims of negative attitudes when they are seeking help in our hospitals. I mean, generally, that's what happens. And so you can imagine a young girl who is pregnant, already vulnerable, and will have to endure, negative attitudes on the part of professionals. That can worsen their situation. And so in my thinking, we need to look at that angle as well. And for the young girls themselves, once again, how do we strengthen the support system, and again, help seeking structures so that whilst they are pregnant, they still can access help. One thing I must mention that in Ghana, our evidence suggests that if you have 100 people who need mental health care, only 2 of them are able to access one. And the reasons are that we don't have sufficient or enough mental health professionals. The next also is that people are gripped by fear and stigma. And so there's a lot we need to do. I believe that there are a lot of informal support structures that we have not explored. And so as researchers, maybe we will need to start looking that direction and see what interventions we can bring about so that we can end up improving the mental well-being of our young people. Thank you.
Thanks so much. I wonder why I'd like to just thank Agnes as well for her comment in the chat, just updating us on the status of Kenya, which is very important to many of us at Global Watch. So thank you, Agnes. It looks like Sophia has put her question in the chat, which is related to what you were just talking about. You were talking about how do we engage with healthcare workers, but what about parents and the community? What's your thinking about interventions and engagement there?
Yes. So interestingly, for parents, we have the thought about it. I just intimated that look, sometimes their parenting styles are just not too supportive, and we need to engage parents. We are not going to dictate to them, but we need them to have an understanding about how the world has changed, and they need to change or adapt their parenting styles. In terms of the broader community, where we have started from is to engage with our community leaders. In Ghana, we have what we call queen mothers. These are mothers who are just like kings. But what happens is that they are seen as the surrogate mother or mothers for the entire community, which represent their jurisdiction. Now, these queens have the prerogative to bring together all mothers in their communities and provide them with some information. Now, our idea is this: if we can engage these queen mothers and share with them evidence from our research and provide them with information that is helpful, of course, that is evidence-based, they will in turn return to their communities and engage with mothers and parents in general. These queen mothers and kings, or chiefs as we call them, they wield a lot of power and influence, sometimes even more than the president or the members of parliament who may be in that community. People in communities sometimes have higher levels of allegiance to these traditional leaders. And we believe that if we can engage them as partners, then clearly we'll be able to stretch out some support to our young girls through their parents and families. Thank you.
Fantastic. Thank you so much. We are at time, but I wonder if you could just quickly tell us if, I can see there are other questions in the chat, and I'm sure there are in the room as well. Is it okay if we connect people with you via email if they have further questions? And is that okay?
Okay, yeah, I'll be available to engage.
Fantastic. Thank you so much, Nii.
Thank you too. Thank you. And thank you to everyone. I'm most grateful and humbled. Thank you.
Thank you.